These are my disclosures. I'm an inventor and equity holder in Lucid Diagnostics, a company that's making a Barrett's detection device, also consultant for Interpace and US Endoscopy. Why is it important to diagnose Barrett's and manage endoscopic dysplasia? Well, the importance lies in the fact that Barrett's progresses to esophageal cancer. There will now be nearly 18,000 cases of esophageal cancer in the United States. Majority of these are adenocarcinomas, and most people who develop adenocarcinoma will die a cancer-related death. If you look at statistics of stage-specific survival, survival's 5 years is less than 20%. But notice that even with localized cancer, survival's only about 40%, suggesting not only do we have to detect cancer early, but we have to make every effort to try to prevent this particular cancer. What we understand about this disease is that squamous esophagus under reflux injury in some patients is repaired with a metaplastic esophagus. This columnar epithelium can sometimes progress to low-grade dysplasia. In some patients, the low-grade dysplasia can progress to high-grade dysplasia. And this is a stage where we want to perform intervention because the risk of high-grade dysplasia progressing to cancer in the next 5 years is about 50%. We have an opportunity to try to resect or ablate Barrett's esophagus. And we have to think histologically in terms of the layers of it. Barrett's may originate from the submucosal gland. So the goal is to eradicate the mucosa, muscularis mucosa, and get down into the submucosal layer where the cell of origin is. The techniques we have for tackling this are manifold. Mucosal resection is one of the most effective techniques for tackling focal disease. The major advantage of mucosal resection is it obtains a specimen for pathology. Not only can you evaluate the lateral and deep margins, you can also assess for angiolymphatic invasion and make sure there's no cancer present in a patient with hypertension. It has minimal side effects. The disadvantage of mucosal resection, or the limitation, is that it cannot resect the central Barrett, it cannot remove large lesions on blood. Indications for mucosal resection are a high-grade dysplasia in the short segment of Barrett, nodular high-grade dysplasia, and even early cancer, as long as it's a moderate or well-differentiated cancer, no alteration of suppression. In T1A cancers without lymphovascular invasion, the risk of metastases is less than 5%. And we've now even extended mucosal resection to T1 SM1 cancers, where the cancer invades beyond the lamina propria, as long as invasion is less than 100 microns into the segment. The technique of mucosal resection can be performed either with a catheteristic technique or with a band ligation technique. Injection into the submucosal space is required for using this CAP technique. This is the first technique that was developed out of Japan. The area of high-grade dysplasia is suction into a cap, and then the snare around the rim of the cap is used to resect the segment of mucosa with the involved area of dysplasia. This is submucosa and muscularis left after resection has been performed. With a cookie cutter approach, it's possible to resect continuous areas and then retrieve the segment. A second approach, which has become more popular, is the band ligation technique. The reason for the popularity is most people are familiar with band ligation for varices. Doesn't involve looping the snare across the rim, which is difficult. The band creates mucosal polyps. The snare is then used to capture that mucosal polyp and resect it, much like a polypectomy. Quite satisfying to take an area of high-grade dysplasia, localize it with narrowband imaging, resect it in two pieces with mucosal resection, and then 6 months later, you see squamous mucosa replacing the area of high-grade dysplasia. Christian L. and his group over a decade ago looked at high-grade dysplasias and early esophageal cancers and showed excellent survival comparable to surgery. Mucosal resection became the standard of care. Submucosal dissection is an extension of mucosal resection technique. Again, a technique developed in Asia, which can be applied to large lesions greater than 1.5 centimeters, which cannot be resected en bloc with mucosal resection. Can also be applied to fibrotic depressed lesions, which are not amenable to mucosal resection, that cannot be lifted. Submucosal dissection does have a high technical learning rate with high rate of bleeding and perforation, but much lower rate of recurrence than mucosal resection. It's been a challenging technique for American endoscopists because of the high learning curve. This is submucosal dissection in action, large depressed lesion. I have to thank Roy Satikno for this video. Mark the periphery, followed by a small needle knife, this dual knife, to make a circumferential incision. It does require technical skills and constant injection of saline or solution underneath with starch, and then this is a hybrid technique of a circumferential incision, followed by snare resection, and then ablation of remaining vessels to make sure there's no delayed bleeding. Resection techniques are often coupled with ablative techniques to eradicate the remainder of Barrett's and to eradicate flat dysplastic Barrett. Ablative techniques started with multipolar electrocoagulation, followed by argon. Photodynamic therapy was in vogue, but had a lot of side effects. The main ablative techniques that are being used are and cryotherapy. Indications for ablation generally are flat high-grade dysplasia, ablation of remaining Barrett's after mucosal resection, and then select patients with low-grade dysplasia, where low-grade dysplasia is confirmed by a second expert pathologist or panel of pathologists, and then patients understand the adverse events associated with ablation.
This video will reveal the extent of Barrett's mucosa. Esophagus is then washed using a mucolytic guide wire is placed in the gastric antrum and the endoscope catheter. For circumferential ablation, similar to the top balloon, is in the esophageal body. The balloon is centimeter-long bipolar electrode array affixed to its surface. It is passed open, followed by introduction of the endoscope in a side-by-side manner. Using direct visualization, the proximal edge of the electrode is positioned 1 centimeter proximal to the Barrett's. The balloon is inflated in an automated manner, and a dose of energy is delivered approximately 700 to 1,000 microns. This is to the level of the muscularis mucosae. The balloon automatically deflates, and the circumferential pattern of tissue injury is clearly seen. The catheter is then advanced past the area of injury to the next segment of Barrett's to be introduced so the ablation zone can be cleaned using a clear cap placed on the tip of the scope. With a wire, followed by the endoscope, and a second complete set endoscopy 2 months later, which showed approximately 95% areas of residual Barrett's seen under both white and used an endoscope-mounted radiofrequency ablation device at the top of the video image. The cap is positioned over the Barrett's island, seen here in blue light, and the scope is tipped up to achieve tissue apposition. Ablation is performed using the same energy and power density 4 months after the initial treatment. The ablated area is reconstituted.
In a landmark New England Journal paper, this multi-center study by Nick Shaheen showed eradication of 80% non-dysplastic Barrett's and 91% of dysplasia in radiofrequency arm compared to sham. Similar rates of complete response of intestinal metaplasia, which brought radiofrequency ablation as the standard of care for dysplastic patients. So major controversy in the field remains whether low-grade dysplasia should be ablated. The natural history of low-grade dysplasia is controversial. In this large multi-center study of low-grade dysplasia, Pratik Sharma and his group showed that 2/3 of low-grade dysplasia resolved on its own and became non-dysplastic Barrett's without intervention. 1/5 of it, or 20%, persisted as low-grade dysplasia without progression, and only 13% of it progressed to high-grade dysplasia or cancer. On the other hand, the Amsterdam group, the Dutch group, and the SURF study, where 3 pathologists evaluated patients with low-grade dysplasia. Most of these patients were reclassified, but in the small proportion where all 3 pathologists agreed, this was 27% of their patients. The patients with low-grade dysplasia progressed to high-grade dysplasia or cancer at a rate of 27% over 3 years versus 1.5% in those who got radiofrequency ablation. 9% in the non-ablated group progressed to cancer versus 1.5% in the ablated group, suggesting that ablation of select low-grade dysplasia patients, those where 3 pathologists agreed, is of benefit. This is the Kaplan-Meier curve from that SURF study, again showing better response to those who were ablated in terms of progression compared to the sham group. Issues to consider when deciding whether or not to ablate low-grade dysplasia or that low-grade dysplasia is not a well-defined entity. There is poor inter-observer agreement. Low-grade dysplasia may regress without any intervention, as shown in Pratik Sharma's study. Progression of low-grade dysplasia to cancer in most studies is similar to non-dysplastic Barrett's. Ablative therapy does have some morbidity and cost, and recurrence of intestinal metaplasia after ablation may be as high as 40% after 5 years. On the other hand, if the right low-grade dysplasia patients are selected, clearly, as the SURF study suggests, there is benefit to ablation. What is the Achilles heel of ablation? The presence of buried glands, and these require continued surveillance. All patients after ablation need continued surveillance, and it's important to pay special attention to the gastric cardia because dysplasia appears to march south, and this is where most recurrences happen, and this is where patients can develop cancer. What are current guidelines on endoscopic eradication therapy? ASGE recommends we confirm diagnosis of dysplasia with an expert GI pathologist. If low-grade dysplasia is present, consider endoscopic therapy versus surveillance. Surveillance is certainly an option in patients who want to avoid the side effects of endoscopic therapy. For high-grade dysplasia and for mucosal cancer, it's clear that endoscopic therapy is the right treatment, and ASG recommends against surgical resection. Once you undertake endoscopic therapy, the goal is to resect all visible lesions, ablate flat high-grade dysplasia, ablate remaining Barrett's, but continue close surveillance. The European Society has slightly modified guidelines, which also take into account the length of the Barrett's. All patients with Barrett's over 10 centimeters with confirmed low-grade dysplasia, high-grade dysplasia, or early cancer are referred to an expert center in Europe. Expert centers are defined as those with annual case volume of greater than 10 new patients who undergo endoscopic therapy, an endoscopist who's trained in ablation therapy, and an expert GI pathologist, and the multidisciplinary approach combined with thoracic surgery, oncology, and radiation oncology. They recommend that visible abnormalities be removed by means of endoscopic resection techniques in order to obtain optimal histopathologic staging, and flat dysplasia and remaining Barrett should be ablated. So in summary, endoscopic and eradication therapy is a major advance in Barrett's esophagus. It can eradicate high-grade dysplasia and likely prevents cancer. Cancer may still develop in these patients, especially submucosally, so close surveillance is necessary. Ablation of low-grade dysplasia is an increasingly attractive option in patients who accept the adverse events of ablative therapy. But our holy grail remains a single-session complete ablation without buried glands, possibly combined with medications that reprogram our stem cells to promote squamous epithelial growth. Thank you.